ERA or ERA, endometrial receptivity analysis, the best option for evaluating endometrial receptivity and to determine the optimal timing for embryo transfer, maximizing the chances of pregnancy without losing good embryos. Let's talk about the objectives of this course. First, to acknowledge the role of the endometrial factor in implantation failure. Second, to introduce the concept of human endometrial receptivity. Third, to learn about ERA, the diagnostic technique aimed at investigating the endometrial receptivity. And finally, to evaluate the ability of the ERA test to better define the window of implantation in patients with recurrent implantation failure that allows a personalized embryo transfer. First, we will introduce the topic. Next, we will explain the ERA test, its importance and procedure, and briefly describe the clinical outcomes of the test. We will also talk about test limitations, and finally, summarize with conclusions. Introduction. The evaluation of endometrial factor is critically important in assisted reproduction treatments. Problems with the endometrial lining are one of the leading causes of infertility in women. The interior of the uterus is lined with a tissue called endometrium. Every month, the endometrium undergoes changes in preparation for the arrival of an embryo. Following implantation of this tissue, the embryo further develops during pregnancy. When this process fails or doesn't occur, menstruation begins and the endometrial lining is shed. For varying reasons, embryo implantation is not always successful. A particularly important factor is endometrial receptivity. The endometrium is receptive when it is ready for embryo implantation. This period of receptivity is called the window of implantation. The window of implantation is a short period of 3 to 6 days during which the endometrium is receptive to blastocyst implantation. Implantation of the human embryo only takes place during this period, which usually occurs between days 19 and 21 of the menstrual cycle. That is 5 to 7 days after ovulation. However, 3 in every 10 patients have a displaced window of implantation, and it occurs a few days before or after, so that if the embryo transfer occurs within these standard days within these women, implantation failure may result. Identification of the endometrial window of implantation in the clinical setting should enhance the outcome of fertility treatments such as IVF. Recurrent implantation failure is an unaddressed major cause of infertility, the main limiting factor for success in vitro fertilization cycles. Although various definitions for recurrent implantation failure exist, the clinical community agrees that after the failure of 3 IVF cycles, in which 1 or 2 morphologically high-grade embryos are transferred, special protocols should be followed. Recognized or suspected causes of recurrent implantation failure are usually grouped into 3 categories, involving the uterus, the embryo, or the environment in which both interact. For this reason, recurrent implantation failure patients may have a displaced window of implantation, leading to embryo transfer into a non-receptive endometrium. The endometrial gene expression signature allows the evaluation of endometrial receptivity, identifying a personalized window of implantation for each patient. This analysis is carried out by a tool designed, developed, and patented in 2009 by Egenomics after more than 10 years of research. Identifying the window of implantation in the endometrial cycle of each patient enables us to personalize embryo transfer. Research by Egenomics has demonstrated that synchronization between the implantation-ready embryo and a receptive endometrium increases the chances of success in an assisted reproductive treatment. Other groups have also published similar results from their own patients after guided embryo transfer, according to ERA results. General concepts. The ERA is a diagnostic test that can identify the receptivity status of an endometrial sample and to determine the personalized window of implantation of a given patient, regardless of the sample's histologic appearance. ERA establishes the time when the endometrium is receptive and reports the optimal time for personalized embryo transfer. The ERA test can increase the chances of pregnancy by synchronizing an implantation-ready embryo with a receptive endometrium. The ERA test is indicated for any woman who wants to improve her chances of pregnancy from the first IVF cycle. For recurrent implantation failure patients, since they are at a higher risk of having a displaced window of implantation. Therefore, this analysis could be beneficial for patients with 2 previous failed cycles with their own oocytes or 1 previous failed cycle with ovum donation in which good quality embryos were transferred. In the case of an atrophic less than 6 mm or hypertrophic more than 12 mm endometrium, ERA can be performed as long as the endometrial appearance is consistent for all cycles for this patient. Procedure. To perform an ERA test, a small endometrial biopsy should be taken from the uterine fundus using a Pipel catheter or similar. When taking the endometrial biopsy, it is very important to take the correct quantity of tissue, around 70 milligrams, which corresponds to tissue with sides of approximately 7 millimeters. Ensure that the sample is made up of endometrial tissue, not solely blood or mucus. Excessive amounts of blood or mucus should also be avoided. It is important not to exceed the white line marked on the cryotube in order to avoid possible degradation of the genetic material. After the biopsy has been performed, the sample should be transferred immediately to the supplied cryotube containing 1.5 of RNA later, a solution to preserve the genetic material, and shaken vigorously for a few seconds. The Pipel catheter used to collect the sample must be discarded as a residue of medical services through waste managers authorized to treat it, always in compliance with current legal regulations. The cryotube containing the sample should be transferred to a refrigerator 4 to 8 Celsius, 39 to 46 Fahrenheit straight away and should be stored there for at least 4 hours. After this time, samples may be sent to Egenomics at room temperature. Samples may also be kept in a refrigerator for up to 3 weeks or may be frozen at -20 Celsius, -4 Fahrenheit after the first 4 hours at 4 to 8 Celsius, 39 to 46 Fahrenheit, if they are not being sent to Egenomics straight away. The test results are available in 10 to 15 calendar days from sample reception by Egenomics. The hormone replacement therapy cycle involves treatment with estrogen and progesterone to inhibit endogenous production of these hormones using the routine protocol at the clinic or our standard protocol. Patients perform estradiol therapy from the first or second day of the menstrual cycle. Ultrasound assessment is performed 7 to 10 days later. Start the progesterone P4 intake when a trilaminar endometrium of greater than 6 millimeters is reached with a serum P4 of less than 1 nanogram per milliliter within 24 hours prior to starting exogenous P4, continuing with estradiol treatment. The day on which the P4 treatment starts is referred to as P+0, and the biopsy is taken on day P+5 after 5 full days. 120 hours from the first intake to biopsy collection. In a natural cycle, HCG, recumbent or urinary, is administered according to routine parameters in a natural cycle, follicle size more than 17 millimeters. The day of the HCG administration is considered as HCG+0, and the biopsy will be taken 7 days later at HCG+7, 168 hours after HCG triggering. This test uses next-generation sequencing, NGS technology, to measure the expression of 248 genes involved in endometrial receptivity. After sequencing the genetic material, RNA, from an endometrial biopsy, an in-house designed computational predictor analyzes the data obtained, classifying the endometrium as receptive or non-receptive at any specific time during the endometrial cycle. This result will be coupled to a recommendation for personalized embryo transfer according to each patient's specific endometrial profile. The ERA report will indicate the optimum time to perform personalized embryo transfer or when to perform a new ERA biopsy as appropriate. To enable reproducibility of results, the ERA test must be performed under identical conditions as the subsequent embryo transfer cycle type, treatment, method of administration, and always during a hormone replacement therapy, HRT, or natural cycle. This test cannot be performed in controlled ovarian-stimulated cycles. The aim of this test is to provide physicians with an objective molecular diagnosis of the patient's endometrial reproductive health. Results. 2 types of results are possible: receptive or non-receptive. A receptive endometrial result shows that the endometrium is ready for the embryo implantation. This profile can be divided into 3 subcategories. A receptive result indicates that the moment the biopsy was taken was the optimal transfer time to allow implantation. In this case, the recommendation is to perform a blastocyst transfer following the same protocol and timing utilized during the ERA test. An early receptive result is concordant with an endometrium at the beginning of the receptive stage. The recommendation is to administer progesterone, HRT, or rest natural cycle for 12 hours more relative to when the biopsy was taken before performing the blastocyst transfer. A late receptive result is concordant with an endometrium at the end of the receptive stage. The recommendation is to administer progesterone, HRT, or rest natural cycle for 12 hours less relative to when the biopsy was taken before performing a blastocyst transfer. A non-receptive result means that the window of implantation is displaced and the endometrium is either pre-receptive or post-receptive. A pre-receptive result is concordant with an endometrium at a pre-receptive stage. In this case, the patient needs 1 or 2 more days of progesterone exposure with respect to the day of the cycle on which the biopsy was taken to achieve the optimal receptive stage. A post-receptive result is concordant with an endometrium at a post-receptive stage, and the endometrium has already passed the ideal window for embryo implantation. In this case, the patient needs 1 to 2 fewer days of progesterone exposure to achieve receptive status. In addition, we can obtain a proliferative profile result, which generally indicates that the endometrium has not been exposed properly to progesterone, or the patient's endometrium does not respond well to that progesterone protocol. It is recommended to contact the ERA laboratory to evaluate the protocol in which the endometrial biopsy was performed. The ERA test has been performed on thousands of women in over 90 countries and more than 2,700 clinics. Of the samples we obtained, 69% were receptive and 31% were non-receptive. In the non-receptive cases, 89% were pre-receptive, 10.5% non-receptive, and 0.5% were proliferative. In approximately 5% of samples received, a result cannot be obtained. This is due to a non-informative profile. In this case, the sample could not be diagnosed because the result was chaotic, and the profile does not match with any stage of the menstrual cycle in our predictor. It is recommended to contact the ERA laboratory to evaluate the protocol in which this endometrial biopsy was performed. This occurs in less than 1% of cases. An insufficient RNA result shows that it was not possible to determine the gene expression profile of the sample because there was not enough genetic material due to too small of a sample or because the sample is mostly all blood and/or mucus. This occurs in approximately 2.5% of the samples received. It is necessary to evaluate a new endometrial sample. An invalid RNA result shows that it was not possible to determine the gene expression profile of the sample due to the poor quality of genetic material obtained, mostly due to too large of a sample size or high amount of blood and/or mucus that can interfere with the RNA stabilizing buffer to penetrate the tissue and preserve the RNA, or due to too high temperatures exposure. This occurs in approximately 3% of the samples received. It is necessary to evaluate a new endometrial biopsy. If the patient results are receptive or pre-receptive, but needing just 1 more day with progesterone, personalized embryo transfer is advised, following the specific recommendations provided in the report. This occurs in more than 90% of samples. The second biopsy is only required for patients with a pre-receptive result needing 2 more days with progesterone or patients with a post-receptive result. In cases of proliferative, non-informative, non-valid RNA, or insufficient RNA result, the test should be repeated. Our recent randomized study proves that a personalized embryo transfer is superior to the classic frozen embryo transfer and shows that the pregnancy rate using ERA in patients starting assisted reproductive treatments is 72.5%, and 7 in 10 women gave birth after 1 year. Personalized embryo transfer is superior to frozen embryo transfer or fresh embryo transfer, not only in cumulative live birth but also in pregnancy and implantation rates at the first embryo transfer and after 1 year follow-up, showing that implantation occurred for 57% of transferred embryos in the first embryo transfer and 95% became pregnant after 1 year. We can conclude that personalized embryo transfer increases cumulative live birth delivery rate plus 16 percentage points versus frozen embryo transfer. Why choose the Egenomics ERA test? ERA is backed by 21 publications, 13 from Egenomics and 8 external publications, and by a randomized study that shows its applicability in patients without any prior assisted reproductive treatment. Thanks to our proprietary algorithm based on machine learning, in 90% of ERA cases there is no need of a second biopsy. And ERA allows clinicians to identify transition phases with 12-hour shifts, factors that may affect the test. Transcriptomic analysis uses messenger RNA, sensitive genetic material that degrades quickly if strict conditions, including shipment and storage temperatures, are not adhered to. For this reason, in approximately 5% of samples received, a result cannot be obtained. This is due to a non-informative profile or to the low quantity and quality of the genetic material extracted. If this should occur, a new biopsy will be required. This test cannot be performed in controlled ovarian-stimulated cycles. Following ERA report recommendations does not guarantee implantation. Failed implantation may be caused by other factors, such as poor embryo quality, genetic abnormalities, or previous pathologies that can also reduce the likelihood of becoming pregnant. The ERA does not test for any other endometrial pathology and does not assess or provide a prediction for the health of pregnancy. Conclusions. The endometrial factor plays a key role in embryo implantation. Synchronization between an implantation-ready embryo and a receptive endometrium increases the chances of success in an assisted reproductive treatment. The endometrial gene expression signature allows evaluation of endometrial receptivity, identifying a personalized window of implantation for each patient. Identifying the window of implantation in the endometrial cycle for each patient allows us to personalize embryo transfer according to the result. ERA determines the optimal time for the endometrial cycle to perform embryo transfer, increasing the chances of pregnancy by synchronizing an implantation-ready embryo with a receptive endometrium. Egenomics, with science on your side.